So we have a couple of questions here. The first one is for Dr. Dillon. Does autoimmune affect neuroendocrine tumors in any way or other autoimmune hormones conditions? I think the question is any, autoimmune diseases affect neuroendocrine tumors or maybe associated with other autoimmune conditions.
Right. So there is one autoimmune condition that comes to mind that actually can cause neuroendocrine tumors, and that is the autoimmune condition called chronic atrophic gastritis or chronic autoimmune atrophic gastritis, which is an inflammatory process in the stomach, which decreases the stomach acid. And when you decrease stomach acid, your stomach responds to that by increasing gastrin, and the gastrin then increases the growth of the neuroendocrine cells of the stomach, so you get carcinoid polyps. Usually those are on the benign end of carcinoid tumors. So that's one tie-in with autoimmunity. I'm not sure that I know other tie-ins with autoimmunity. I don't see that as a regular relationship. Unless somebody had some specific question about a specific autoimmune condition and a specific tumor.
Maybe the autoimmune with pernicious anemia and type 1 gastric neuroendocrine tumors.
Right. So the pernicious anemia, chronic atrophic gastritis, that's, it's one of the few neuroendocrine tumors where we actually pretty much know the cause, because and of course those tumors can be seen also in people who take enough omeprazole or pantoprazole for long enough to cut down the gastric acid, because that increases the gastrin in their stomach, which can cause carcinoid polyps.
Okay. So the second question for Dr. Ramirez: when would you order a PET FDG for your patients?
So there's two different types of PETs that we generally use. So we talked a lot about the dotatate PET CTs that will detect presence of somatostatin receptors on the tumor. The other type of PET CT is called an FDG PET. What this PET does is, and we use it a lot. In my lung cancer patients, they all get FDG PETs, but this detects more metabolically active tissues. So when we get a PET, there's certain things that will light up on the FDG PET that are completely normal. So for instance, the brain lights up, the heart can light up because it's squeezing and is very active. Infections can light up. Cancers light up as well, including neuroendocrine tumors. But when we look at we assign values to the degree of how much they light up. So if you read a report on your PET, either FDG or dotatate PET, you'll see something called SUV. So that stands for standard uptake value. Now, essentially, it's like a contrast on your TV. The brighter the contrast, the brighter it lights up, the higher the number goes. And in FDG PETs, very aggressive cancers will have high numbers. So we often see in our lung cancer patients, for instance, SUVs 30, 40, 50. In our low-grade neuroendocrine tumors, they'll light up too, but the SUVs will be 3, 4, 5, something like that. So I primarily will get FDG PETs for patients with those higher grade tumors, and that kind of gives me an idea how aggressive these things are. In other cancers, we get the PET. If your SUV is 50, for instance, I give you chemotherapy. Get another PET, I would expect that SUV to drop down. So in the dotatate PET CTs, it doesn't work like that. So we just look at those numbers. So I wouldn't pay attention to those too much. But primarily, to answer the question, the FDGs are useful in the higher grade tumors normally.
Okay. Next question for Dr. Dillon. How is the grade inflation treated with? I don't understand the rest of the question, but I think the question is mainly about the grade inflation, how you detect it and how you treat it.
Thank you. So I am lucky enough to work in a multidisciplinary group. I am an endocrinologist. Generally, when we get to talking about grade of tumor, I am talking to my medical oncology colleague. Grade of tumor relates to how much proliferation is going on in the tumor, how aggressive the tumor is. All of the tumors that are grade 3 are being dealt with pretty much solely by my medical oncology colleague. So I'm not sure I'm the one to answer a grade and grade inflation question.
So, Ramirez, do you want to add something before I go? Okay. So usually, basically, we get the first grade at the diagnosis, and then the second time I'm going to expect a grade inflation or change in the grade if the patient did not respond to my treatment. I usually try to get another imaging and maybe get another biopsy for these patients. And the grade will make a significant difference in how we treat our patient. So if the patient was a grade 1 and grade 2 and they have good somatostatin receptor expression, the next factor I'm going to look at is the tumor burden, how much tumors they have, and where is the location of these tumors. Is it only hepatic or is it also extrahepatic as well? And according to that, we'll discuss in the tumor board the role of surgery, liver-directed therapy, and all the systemic therapy as well. But let's say a grade 1 or grade 2 patient, I start them on somatostatin analog, and then suddenly after a couple of months, they have aggressive disease progression, which is not expected for lower grades like that. At this point, I may actually order a PET FDG for this patient, even if they have a good somatostatin receptor expression to start with. I may get another biopsy, and if I found change in the grade from grade 2 to grade 3, I may consider chemotherapy for this patient, especially for the one who have pancreatic neuroendocrine tumors. So the grade inflation were really detected by how they respond to the treatment and what is the course of the disease, which sometimes, you have patient, again, with a grade 1 or 2, you suspect they will be stable on somatostatin analog for a long time, but that's not the case. With the second imaging, after a couple of months, you find this aggressive progression. So it depends how the patient respond and what type of treatment I start with, and do I need to get another biopsy or not. You want to add something else?
No, I think that sums it up.
It's a question for both of you. What make a specialist a specialist? It's an interesting question.
Right. There in the medical profession there are training programs for oncologists. There are training programs for endocrinologists, and there are board examinations for these things. And there actually are no formal training programs for neuroendocrine specialists. It is a sort of an add-on after one has gone through oncology training most often. I'm a bit of a zebra within endocrinologists as an endocrinologist who is interested in this. I think that what makes a specialist is how many of these folks you see and what proportion of your practice is neuroendocrine patients. So my sense with oncologists, a general gastro-oncologist would see 2 or 3 or 4%, 5% of neuroendocrine patients. They keep on coming back, so because they live longer, but most of their patients are going to be non-neuroendocrine. So I think the critical thing is what your depth of experience is. There is no board examination for that.
Yeah, I agree. When we do our specialties, we can, as an oncologist, we've got various pathways that we can go. for instance, my wife is a medical oncologist as well, but she is a general medical oncologist. She sees everything that comes through the door. And I don't know how she keeps up with it all. But she sends people out if they need to see someone who is truly focused in that. She doesn't have any neuroendocrine patients. She sends them to me. But I think, you know, it depends on where you're at, the level of specialty. At Vanderbilt, we are so pigeonholed in our little niche. We've got, you know, so 95% of what I see nowadays is neuroendocrine. And I see lung cancer that as well. That's the other 5%. My partners, we've got people who only see sarcoma or only see colon cancer. And so that's what, you know, that keeps us focused. That keeps us on top of the latest findings. That helps us drive the field forward in our own research as well. And I think there is certainly nothing wrong seeing a general oncologist. And we work with people. Most of our referrals are from general oncologists, you know, who that's the community. That's where most of oncology care happens, is in the community. It's not at the big academic centers. But we always work with that referring doctor and sort of provide that roadmap and say, all right, this is what you should be doing at home. I'll work with you to get your patient, you know, set up with this sort of treatment, and then any big picture decisions, then they come back to us and say, no, we need to change therapy. We can either do it here if it's an operation or embolization or so. If it's a medical therapy that can be done 200 miles away from me, well, then you need to go back and have your own oncologist do this. If they're local, then we do it. But yeah, there's a lot that goes into it. I encourage everyone to have a specialist. At least see a specialist at least one time to really get, you know, another set of eyes on things.
It's really a building experience. So, you know, you start your niche or your interest in specific type of tumors. You try to attend annually the conference for this tumor specifically. Like for neuroendocrine, we are grateful to have NANETS and ENETS, both of them. And that's where really every year we build our update experience. What is new in the field? What type of clinical trials looks promising? Some data about new treatment or the side effects, stuff like that. So I think building your knowledge every year with this conference, try to see a lot of patients with this specific specialty will make you learn every day about new cases, about new complications, about new type of weird presentations that you may not exposed before. To have specific peoples with the same interests that you have in building a neuroendocrine tumor board, so you share your ideas and your experience. I think all that just building your experience slowly on the field until you become a specialist, in my opinion. There's some criteria for ENETs, what we call the Centers of Excellence, which we did not agree with it all the time that you really need that. But one of the interesting is they define the high volume neuroendocrine tumor cancer centers that you should, I think, see 200 plus neuroendocrine tumor patient a year. It doesn't need to stick with the 200, but I mean, it gives you some criteria that you have to be clinically heavy volume patients in your center, so you see a lot of complicated cases. You present it at the tumor board. You share second opinion with your colleagues around the country. That's really what makes you slightly know more in this field maybe than others who see everything else.
Yeah, I could just off cameras. It's who is that? No, I could just add something, because we don't officially rate experts, but of course we're looking for experts. So I think it's very much based on the number of patients in your clinical practice. How much research have you done? That's another big one. Doesn't mean you have to be only a researcher. And also membership in NANETS is part of it. You could chime in too. Anybody who thinks that they have something important in a specialist, because there is no rating as a NET specialist. But all these things come into practice. And of course, us and other organizations have people who speak at these conferences, and the depth of knowledge that you could see in a speaker certainly speaks to the fact of whether they're might be an expert or not. So it's not subjective 100%, but of course you do get to see what your doctors know when they speak at a conference, how many patients they see. Those are all important things.
Another question for Dr. Ramirez. What is the role of the SPRT in treating neuroendocrine tumors?
Yeah, so I touched on this briefly in my talk. So this is high dose radiation. So they're external beam radiation, so different than Lutathera or PRRT. So usually with lung cancers, if we're giving radiation, we do sort of a low dose radiation over a course of sometimes 6 weeks. So Monday through Friday, we take Saturday and Sunday off because cancer doesn't grow on the weekends. But that's what my radiation oncologists say anyway. But it's a long course. But more recently in the last decade or so, we have learned in non-small cell lung cancer, so the smoking related type of lung cancer, we can do high dose radiation over a course of usually about 5 days. Where this came from is in patients with lung cancer, they often have pretty diseased lungs. So they've smoked for a long time in many cases. Their lung function isn't that good, and then they go to the surgeon, and the surgeon says, well, in order to get this to fix it, to get rid of your tumor, we need to take it out. Well, if I take out part of your lung, that's going to decrease your lung capacity, and based on your chronic lung disease, that's not a good idea. You're not a surgical candidate. So then we turn to SBRT and say, all right, well, if we can't take it out, we cook it with radiation and kill that off. And the studies have been very positive in those patients with the early stage lung cancers that are not candidates for surgery. This offers them a chance for cure. Fast forward, after, SBRT's been around for a long time, but nobody had ever really looked at it in pulmonary carcinoid tumors. So we looked at our data, and said, wait a minute, this is, sometimes the thinking is, radiation doesn't work with these. Radiation works great with these types of tumors. So same kind of thing. It'll kill that tumor off, in those patients who are not candidates for surgery. I've used SBRT in patients with who have so pancreatic neuroendocrine tumors, for instance, who have lung metastases, and everything is stable except we've got one spot in the lung that's growing. We can do SBRT for that what we call oligometastatic disease. So it works great. It's very well tolerated, and it's and most people do really good with it.
Another question, I think I can take this one. How much time does the primary will take to grow back if it is removed? I think that's depend on your pathology. So for example, if you are a patient with high-grade neuroendocrine carcinoma, we usually do not recommend surgery from the beginning because the risk of recurrence is very high, and it's very high aggressive cancers. So usually we recommend chemoradiation, for example, for these patients. If you are well-differentiated neuroendocrine tumor, it depends on your grade. So if you are someone with a grade 1 indolent disease, it was a small tumor, I think it will take a longer time overall than someone else with a grade 2 with tumor was larger and have positive lymph nodes. So it depends on your pathological, I think, diagnosis, in your grade, in your differentiation. That's really will affect how fast the cancer may come back. And some patients, they may pass the 10 years without the cancer coming back, and they present with late presentation. I have some patient with colorectal, actually, neuroendocrine tumors with a grade 1. They came 20 years to me back, like they inherited to other pathologists before me, and then they came to me with, again, another recurrence of neuroendocrine tumor, and it was a grade 1. So it'll give you an idea how long it takes for another recurrence. So usually it depends on the differentiation, grades, the size of the tumor, if there's any positive lymph node or not at time of surgery, all these factors. Do you have something else, Ramirez, to add? So another question is, how they diagnose neuroendocrine tumor from the beginning? I assume what type of symptoms will make you think that this patient may have neuroendocrine tumors?
So neuroendocrine tumors, what the symptoms that I was talking about related to the carcinoid syndrome, those are present in only 20% of people. So you're not going to pick they are important symptoms. So if a person starts having this unusual flushing over time, or starts having issues with diarrhea that are not clearly attributable to some other more common cause of diarrhea, it's important to consider neuroendocrine tumors. But more neuroendocrine tumors are picked up by virtue of their tumor aspect rather than their secretion aspect. So their tumor aspect in the lung, it would be pneumonia, it would be cough, wheeze. We've heard the symptoms in the abdomen, blockage of the abdomen, other pain in the abdomen, and many people just being picked up incidentally. They come in with a motor vehicle accident, get an X-ray, and there's something there. I'm not sure if that answered the question.
No. Another question, can we donate organs or blood if you have neuroendocrine tumors?
My recollection was no when this came up before. I don't know if other people have other idea about that. I guess because people with, as I understand it, people with metastatic cancer are not donors.
Yeah.
Are not acceptable donors. And the question arises when you're, let's say that you've had a pancreatic neuroendocrine tumor and it was, let's say, 2 centimeters and it was removed, and you've had 3, 4, 5 years of no evidence of disease. Can you then donate an organ? I still think that you'll be turned down for donation, but I'm not entirely sure. Maybe Marianne, you have that.
Okay. So since 2001, according to Dr. Odorizio, Dr. Waltering, Dr. Vinnick, Bill Go, who am I missing? I'm missing somebody else. But anyway, we have always been told that we cannot donate blood or organs. The only thing that you can donate is your corneas. Don't ask me why, but that's what all those specialists have always said since I've been diagnosed.
Okay. So the last question, how I can discuss my type of cancer to other people outside who does not know about neuroendocrine tumors? I think any one of you can answer this question.
Okay.
Actually, we have 2 questions.
You want me to
about
take
that
it?
here.
Okay. So, each one of you have a brochure in your pocket, in your little thing. Make a copy of it and hand it to the family. We do personal calls with families. You can schedule a Zoom call, and we'd be more than happy to talk with you and your family to discuss it. I'm going to be honest with you. Since my diagnosis, my children have known about it. I had a friend that had melanoma, and she never talked to her family about it. And she started losing weight, and she was really, really sickly. And her kids kept on coming to me and saying, "What's wrong with mom?" And I kept on saying, "Nothing. Mom's fine. Mom's fine." But they finally did find out. So I always felt that it was important to be honest with my children. I got diagnosed with my lupus at 27 when I was pregnant with Trisha. So Michael was 6 years old, about 6 years old. So he's known that I've been sick. Trisha has never seen me healthy. So my kids grew up with it and they knew about it. The best thing to do is take the information that you have with you and be honest with them and say, you know, yes, this could be a deadly disease, but depending on where your situation is, say it can be controlled as long as I can stay on the medication and I stay on top of it. But like I said, if you want a conference call, we'd be more than happy. We set up Zoom calls, and Robert and I both come, and sometimes Tricia, if there's a young child in your family that needs to be talked to about it, needs support, Tricia gets on the phone with them, and we'll talk to them too, because the kid, like I said, the kid's been dealing with this for 22 years. They grew up with this, so they know how to talk to kids and things like that. We have been working on a book or a coloring book for children to explain what's going on.
This was the last question. Does anyone else have any question?
Yeah, I just put in a question, I don't know where it went to, about octreotide injections, self-injections.
Hold on. 1 second.
We have a paper here. It's a, do your patient have a difficult time finding octreotide,
Yes.
especially the higher doses? I don't know, this was for me.
Yeah, the last couple of times
Yeah.
we have it.
Right. Yeah. So this has been an issue of drug shortages, and it's been very problematic. It's not just with octreotide. It's been with a variety of things, particularly sort of post-COVID and the supply chain issues that we all heard about then. And there are relatively few manufacturers, and some of them don't even make the high dose. I'm not sure that there's my clinic nurse Kimberly Miller is a and I'm sure all of you have a clinic nurse who actually runs your life, thankfully. But hunting down sources of these medications can be incredibly frustrating. Wait around another 2 months and they come up again, and above my pay grade to understand why they come and go. But yes, I acknowledge the frustration.
It's also not only COVID, we have this problem every summer and fall for the last 15 years. So it does happen. You just get the lower dose and give yourself a bigger shot.
He's never been able to get the higher dose, but the lower dose it took us a month to get the last time.
That's it. You get it and you store it and you try to order it as often as possible, as much as they can give you, and put it in your drawer. And as long as it stays in the refrigerator and it's in the dark, it lasts a long time, even after the expiration date. That's the last question? Okay. So I'm just going to quickly close out. Thank you guys. We really appreciate it.